This content is not designed for use as a medical reference to diagnose, treat, or prevent medical illnesses or trauma. If you have questions about the diagnosis, treatment, or prevention of a medical condition or illness, please consult your personal physician.
Hello, and welcome to part 2 of our discussion on head injuries. Now that we've reviewed some of the basics of head injuries in the last lecture, we will focus today on some unusual conditions that can result from head injuries, some specific causes that have received a lot of attention in the media, and some possible treatments. Let's begin by talking about two conditions known to primarily result from head injuries: visual agnosia and prosopagnosia. The word agnosia comes from Greek and means not knowing. There are a variety of agnosia impairments specific to different modalities, including vision, auditory, and somatosensory types. Today, we're going to focus on visual agnosia, which means not being able to recognize an object visually. This condition is modality specific and that the affected individual can recognize objects by touch, sound, or smell, just not by vision. Visual agnosia, it's not a vision disorder per se, as the person can see the object perfectly well, nor is it a naming disorder, as they can name the object if they identify it using their other senses. Here's an example. Let's say you have visual agnosia and you walk into your kitchen and from a distance you see a coffee maker. You could easily describe to me what the object looks like. So its color, edges, and so on. But when I ask you what the object is, you can't tell me. However, if I turn the coffee maker on and you hear it making coffee, you'll be able to identify the sound and tell me it's a coffee maker. And if I blindfold you and ask you to feel the object, again, you'll be able to tell me it's a coffee maker. The only way you fail to recognize the object is by sight. There are two primary types of visual agnosia: apperceptive agnosia and associative agnosia. To understand the difference between these two types, we need to know a little bit about how object recognition works. When we look at an object, features of the object, so its color, edges, light intensity, and so on, travel from the retina to the brain. The brain then integrates all of these features so that we have a complete perception of the object. If some type of error or failure occurs during this process, our perception will be incomplete and we will have difficulty recognizing the object. This is what we refer to as apperceptive agnosia. With normal object recognition, once we integrate the features of the object to accurately perceive it, we then need to make an association between the perception of the object and our stored knowledge or memory of the object. So we're making the link between vision and memory. An impairment in the ability to make this link is what we refer to as associative agnosia. As you can see, a higher level of processing is involved with associative agnosia than with apperceptive agnosia. So how would a clinician distinguish between these two types of agnosia? Well, patients with apperceptive agnosia cannot copy, match, or draw simple figures because they can't integrate all of the features together. Whereas those with associative agnosia can. With both types of visual agnosia, bilateral damage, so damage to both the left and right hemispheres, is typically seen in the posterior occipital or temporal lobes of the brain, sometimes both, as a result of head injury in most cases. Another condition, prosopagnosia, is associated with the inability to recognize human faces by sight. This condition is also called face blindness. The degree of severity can vary. Some individuals may only have difficulty recognizing familiar faces. Others also have difficulty discriminating between unfamiliar faces. And still others may also have difficulty distinguishing faces from objects. Some people are even unable to recognize their own face. Prosopagnosia is not related to vision or memory impairments. It's believed to be caused by damage to the fusiform face area in the temporal lobe, a brain area that controls face perception and memory. This area is larger in the right hemisphere than in the left. As you might imagine, prosopagnosia can be socially crippling, so affected individuals often rely or have to rely on other ways of identifying people, such as by their voices, clothing, ways of moving, or other unique attributes. One of the most common complaints of those with prosopagnosia is that they have trouble following the plot of television shows and movies because they can't keep track of who the characters are. If I were to show you 6 faces on a computer screen, then later I showed you the same faces along with new ones, you probably wouldn't have much trouble identifying the ones you'd seen before. Now imagine the same exercise, only with rocks instead of human faces. You'd probably have a lot of trouble, right? This is how it is for people with prosopagnosia. There's a really interesting case study of a sheep farmer named WJ who suffered from prosopagnosia, though in his case it was due to a stroke rather than a head injury per se. When presented with a variety of famous faces, he couldn't identify who they were, their age, their gender, or even their facial expressions. He could, however, recognize and distinguish among all the sheep on his farm. When doctors studied WJ, they found that he could recognize sheep 80 to 90% of the time, and human faces only 25 to 50% of the time. And when the same study was conducted on experienced sheep farmers without a brain injury, the farmers claimed that their sheep all looked the same to them. I'd now like to turn our attention to 2 causes of head injury that receive a lot of attention in the news: bomb blasts associated with active military duty and sports-related injuries. Blast-related traumatic brain injury, or TBI, typically occurs during war as a result of improvised explosive devices, or IEDs. Approximately 15 to 23% of service members deployed to Iraq and Afghanistan have screened positive for a mild TBI. And 10 to 15% of these individuals report the presence of chronic physical, emotional, and cognitive post-concussion symptoms. IEDs can cause head injuries in 2 ways. One way is from the blast itself. When a device explodes, air pressure suddenly increases as air molecules heat and accelerate, then just as suddenly decreases, producing intense wind. These rapid pressure shifts can directly injure the brain by causing a concussion or even a contusion. A second way IEDs can cause head injuries is by creating blast waves and wind that can propel fragments, bodies, and even vehicles at people, causing a concussion. Most individuals experience a mild TBI from these bomb blasts. The physical effects of a blast like this depends on such factors as the characteristics of the IED, the distance between the person and the blast, whether the blast occurred in an open environment or in a closed space, and whether there were any solid structures between the person and the device. If structures are present, the blast waves could reflect off the various surfaces and lead to multiple pressure waves. These waves can then impact a person from different directions for a prolonged period of time, increasing the severity of the injury. researchers often find it a little tricky to study those who have experienced blast-related TBIs because injuries tend to be fairly heterogeneous. This, in part, is due to various factors that can affect the extent and location of the head injury. But also, in many cases, months to years pass before affected individuals are examined. And many veterans experience multiple TBIs during their lifetimes, which can confound results. Blast-related TBIs also have a high comorbidity with mental health issues, such as depression and post-traumatic stress disorder, or PTSD, making it hard to separate effects of the TBI from these other issues. These injuries are concerning, though, as blasts account for 60% of military-related TBIs. Like TBIs, head injuries sustained while playing sports or engaging in recreational activities have also received considerable news coverage. It's estimated that anywhere from 1.6 to 3.8 million sports and recreation-related concussions occur in the United States each year. These are more often seen in competitive sports, with the highest rates seen among football, soccer, and ice hockey players. Football alone accounts for more than 60% of reported concussions. Thankfully, most of these concussions are mild. Many athletes also sustain subconcussive injuries, which typically occur through some type of collision during play. In these cases, the bump, blow, or jolt to the head does not cause the symptoms we tend to associate with concussions. In other words, they are below the concussion threshold. However, these subconcussive injuries can accumulate and cause long-lasting issues. When it comes to sports-related head injuries, the condition you most hear about in the news is chronic traumatic encephalopathy, or CTE. The bodies of famous athletes who passed away, like Andre Waters, Junior Seau, Aaron Hernandez, and Frank Gifford, all showed post-mortem signs of CTE. So where did this condition come from, and how is it characterized both pathologically and clinically? Back in 1928, a forensic pathologist called Harrison Martland coined the term punch drunk to describe a set of peculiar symptoms that he had observed in professional boxers. These included unsteadiness of gait, mental confusion, slowing of muscle movements, hesitancy in speech, hand tremors, involuntary head nodding, mental dullness, difficulty concentrating, paranoia, memory loss, dementia, rage, and morbid jealousy. These symptoms, which researchers came to agree were caused by repeated blows to the head during boxing matches, soon became known as dementia pugilistica. Then in 1949, to highlight the chronic and progressive nature of the disorder, they changed the name to chronic traumatic encephalopathy. In studying the brains of retired boxers, researchers found neuropathological changes in the cerebral cortex and various other brain structures. For nearly half a century, CTE was thought to only affect boxers. But today, we know that it is far more extensive. In the early 2000s, the disorder was found in individuals exposed to repetitive brain trauma from head-banging behaviors, physical abuse, poorly controlled epilepsy, and military-related blasts, as well as among athletes involved in football, ice hockey, soccer, and professional wrestling. The widespread nature of CTE has caused increasing concern for athletes and their families. CTE is purely a pathological change that is confirmed post-mortem. It's not a clinical condition per se. A joint panel by the National Institute of Neurological Disorders and Stroke and the National Institute of Biomedical Imaging and Bioengineering defines CTE as the accumulation of hyperphosphorylated tau protein in neurons and astrocytes that appear in an irregular pattern. These accumulations, which are perivascular, meaning they occur around a blood vessel, are predominantly seen at the depths of the cortical sulci. As the disease worsens, the tau pathology becomes more widespread, appearing more prominently in the frontal and temporal lobes, amygdala, hippocampus, and entorhinal cortex. Alzheimer's disease also involves the accumulation of tau protein, which is associated with something called neurofibrillary tangles. In CTE, the tau protein accumulates mainly in the superficial cortical layers, usually around the blood vessels. In Alzheimer's disease, the tau protein typically accumulates in deeper cortical layers. So these two disorders share some characteristics at the microscopic level, although they are also distinct from one another. No clinical criteria currently exist for the diagnosis of CTE. Remember that CTE is based solely on pathological changes that are observed post-mortem. There is a clinical syndrome, however, called traumatic encephalopathy syndrome that is associated with repetitive head impacts. It typically appears years after exposure to head trauma, and it may or may not be associated with CTE. Efforts are currently underway to validate the clinical features that best predict the underlying neuropathology. Traumatic encephalopathy syndrome has 4 common clinical manifestations: cognitive impairments, such as those seen in memory, executive functioning, and processing speed; behavioral abnormalities like aggression, paranoia, and impulsivity; mood disorders like depression, anxiety, and suicidality; and motor dysfunction like dysarthria, so difficulty speaking, bradykinesia, which means slowness of movement, rigidity, or gait disturbance. There is still a fair bit we don't know about CTE. Although we know it's associated with mild TBI and repetitive head trauma, we don't know whether a single event TBI can lead to CTE, whether there is a minimum number of TBIs that lead to it, or even whether the severity of a TBI relates to CTE. We also don't know the time of onset for CTE symptoms after the brain injury occurs. Some research suggests a time frame of 8 to 20 years, but this hasn't been validated. So a lot of questions remain unanswered. We also know there are limitations to the research so far. For example, published studies tend to have a selection bias, consistently favoring high-risk symptomatic men as study participants. So existing studies are not representative of the general population. There have also not been any epidemiologic, cross-sectional, longitudinal, or prospective studies on CTE to date. An epidemiologic study might measure the risk and occurrence of CTE in athletes compared to non-athletes. A cross-sectional study could compare various groups of athletes of different age ranges, experiences, and sports played. In a longitudinal study, athletes and non-athletes could be assessed clinically over a period of time that might span years. And in a prospective study, researchers could watch for the development of CTE during a specified period of time and see if it's related to different factors. So since CTE is confirmed post-mortem, is it even possible to detect pathological signs of CTE in the living? It's an open question, and a couple of avenues are currently being examined. The first involves examining blood samples for biomarkers of tau. After a head injury, you could potentially follow someone over time and take multiple blood samples to see whether increases of tau production occur, which is suggestive of neuropathology. In 2016, Robert Stern and colleagues at the Boston University's Alzheimer's Disease and CTE Center examined the presence of tau in 78 former NFL players and 16 controls. The amount of tau measured was significantly higher in the NFL group compared to the control group. The tau discriminated between groups with 82% sensitivity, meaning the ability of the amount of tau to correctly identify someone as being an NFL player, and 100% specificity, or the ability of the amount of tau to correctly identify someone as being a control. In the NFL group, higher levels of tau were associated with worse performance on tests of memory and psychomotor speed. A second avenue for possibly detecting CTE prior to death involves the use of PET scans and radioactive agents known as radioligands that detect and illuminate tau proteins in the brain. One of the first agents used for this was F-18-FDDNP. Many variants of this radioligand are being developed and examined in clinical trials with varying degrees of success. A 2020 study by researchers at the University of California, San Francisco, did find a correlation between the uptake of one radioactive agent, fluortazapur, F-18, and postmortem tau pathology. But the correlation was modest. One would expect a very high correlation if both methodologies were measuring the same thing. Perhaps this radioligand has limited utility as a biomarker of tau pathology in CTE, and other tracers will be more successful. Obviously, this is just one case study, and more PET to autopsy reports are needed to validate or extend these findings. So what type of treatment options are available for individuals who've experienced a head injury? It goes without saying, but the types of treatment, the setting the patient receives the treatment in, and the length of the treatment will all depend on the severity of the injury and the brain areas affected. Remember that a person suffering from a head injury is likely to show physical, emotional, and cognitive symptoms, all of which may require different treatment protocols. There is no specific treatment plan for a mild brain injury except rest and the restriction of physical and mental activities. This may include restricting sports, video games, TV, computers, or too much socializing, especially in crowded environments where noise levels are high. Balancing rest and activity are important for recovery, and the affected person should make a slow return to normal activities, taking frequent breaks to aid in the recovery process. If they return to normal activities too soon, symptoms will reappear and the healing process will be delayed. Moreover, alcohol and other drugs can slow recovery and increase the chances of re-injury, which in turn can increase the chances of long-term problems, including permanent brain damage and even death. With more severe head injuries, it's not uncommon for a variety of medications and rehabilitation therapies to be incorporated into an overall treatment plan. The types of medications prescribed will depend on the types of symptoms individuals exhibit. Medications commonly prescribed to head injury patients include anti-anxiety meds, anticoagulants, which are used to prevent blood clots and improve blood flow, anticonvulsants or seizure prevention meds, antidepressants, diuretics, which help remove fluid that can increase pressure in the brain, muscle relaxants to reduce muscle spasms and relax constricted muscles, and stimulants to increase alertness and attention. In addition to medications, a variety of rehabilitation therapies can be used to help the individual recover functions, relearn skills, and find new ways to do things. These include therapies for physical, emotional, and cognitive difficulties that can help patients with activities like daily self-care, driving, and interacting with others. Depending on the injury, Treatment may be needed only briefly, over a period of time, or on an ongoing long-term basis. Therapy typically begins in the hospital and then continues in places such as rehabilitation centers, skilled nursing facilities, homes, schools, and outpatient programs. Common types of rehabilitation therapy include physical therapy to help build physical strength, balance, and flexibility, occupational therapy to relearn how to perform daily tasks like getting dressed, cooking, and bathing, speech therapy to improve the ability to form words, speak aloud, and use other communication skills, psychological counseling to learn coping skills, work on relationships, and improve emotional well-being, vocational counseling to help the patient return to work by finding appropriate jobs and learning how to navigate with work-related challenges, and cognitive therapy to improve memory, attention, perception, learning, planning, and judgment. The future of treatment for traumatic brain injury leans toward a focus on neuroprotective approaches. This means examining methods that can be used to classify and target mechanisms involved in the secondary injury cascade that follows the primary injury people experience. As we know, this secondary injury cascade can result in neurometabolic and neurochemical events like inflammation, cerebral edema, disruption of the blood-brain barrier, oxidative stress, excitotoxicity, and mitochondrial and metabolic dysfunctions that can extremely modify the outcome and recovery pattern of an individual post-injury. A neuroprotective approach will try to minimize the damage caused by this cascade by creating therapies that can stimulate the recovery and functioning of non-neural cells and inhibit the underlying mechanism responsible for neuronal cell death. Experimental treatments include the use of neuroprotective, neurorestorative, and anti-inflammatory agents. If the secondary injury cascade can be stopped in its tracks or even reversed, it could have important recovery implications for the individual. Researchers are currently working on possible treatments that follow this approach, and hopefully human clinical trials will enable them to be used in the near future. We've now come to the end of our two-part discussion of head injury. In our next lecture, we'll examine multiple sclerosis. Bye for now.